Series is an initiative of the University of the Philippines Medical Alumni Society. It delves on important, current, and emerging medical topics and is targeted for physicians, especially general practitioners, occupational and industrial health doctors, primary care physicians, family and community medicine physicians, and other health workers. It is held every Wednesday from 12 noon to 1 p.m. Manila time. Registration is free. This webinar runs on the UP Manila live streaming platform at livestream.upm.edu.ph. If you have difficulties in accessing the webinar through the live stream page, please watch the live video on our Facebook page. This session will run for an hour with 30 to 45 minutes allotted for a lecture, followed by a question and answer portion. To participate in the webinar, please use the Q&A box found on the live stream page. For Facebook participants, please type your questions in the comments box. Please only use the comment section for questions and other webinar concerns. An evaluation link will be emailed to you after the webinar. Please answer it to get a copy of your certificate. May we now call on our moderator, Dr. Tigran Romeo-Odi, who is an associate professor at the UP-PGH Department of Anesthesiology and is a member of the celebrating class UPCM 1994.
Good afternoon, this is Dr. Tigran Odi, speaking from the IMS building, Patio Flower Street, Ermita, Manila. Today's webinar is entitled The Burden and Consequences of Residual Paralysis and Value of Neuromuscular Monitoring. The objectives of today's webinar are: 1. To describe the problem of residual paralysis after emergence from anesthesia. 2. To discuss strategies for prevention of this problem, especially the value of neuromuscular monitoring. And 3. To discuss the treatment of this post-operative complication. Our speaker today is Dr. Merle Odi. Dr. Odi is a retired professor of anesthesiology at the UP College of Medicine. She is currently Chair, Board of Trustees, the Philippine Board of Anesthesiology, or the PBA, Vice Chair of the Philippine Board of Pain Medicine, or the PBPM, Chairman of the Board, the Pain Society of the Philippines, PSP, and a member of the Board of Directors, Society of Neuroanesthesia of the Philippines, or the SINAPS. She's also the founding president of the Society of Neuroanesthesia of the Philippines and is a past president of the Asian of the Asian Oceanic Society of Regional Anesthesia and the Philippine Society of Anesthesiologists Incorporated. She was as well the chair of the Department of Anesthesiology, Philippine General Hospital, University of the Philippines, Manila, and of the Department of Anesthesia, the Medical City. She's a multi-awarded medical professional, but unknown to many, is also a mezzo-soprano of the Cultural Center of the Philippines. May we now call on Dr. Merle Odi.
Good afternoon. Thank you very much for that very wonderful introduction, Ding. It is a pleasure to be invited to the UP College of Medicine Class 1994, by the UP College of Medicine Class 1994, and to be one of the speakers of the UPMAS webinar series. At the end of this lecture, the listener will be able to define residual neuromuscular paralysis or block, enumerate and discuss the consequences of residual neuromuscular paralysis, describe how monitoring and reversal can prevent residual neuromuscular paralysis. An American virologist, Dr. Paul, introduced the term the hidden universality of infection to describe the clinically apparent infections typically are far outnumbered by those patients in whom the meaningful infection produces no sign or symptom of disease. Along the same line, in his letter to the editor, Michael M. Todd, an American anesthetist of Iowa University with an interest in clinical implementation science, emphasizes the hidden universality of residual neuromuscular block, posing the question as to whether or not its high occurrence is still an acceptable normal practice. Residual periodization, or the hidden universality of residual periodization, was initially brought to our attention by the anesthetist in 1971 by Dr. Jan B. Mogensen and his colleagues, who reported a 42% incidence of unidentified residual neuromuscular block in the recovery room. Through the years, the incidence of postoperative residual paralysis has been written about by many authors in Europe and in Canada. And as you will note in this slide, the incidence is quite high, and the highest one is the one reported in Germany, which was 57%. 35 years later, the group of Martinez Ubieto conducted another study and found that of 558 patients, 27.9% presented still with postoperative residual pluralization or residual paralysis in the PACU. And this was associated with minor and major pulmonary complications. Murphy also sometime in 2015, again 35 years later, he included in his study 150 elderly and 150 younger adults patients. And he noted that the elderly are at increased risk for postoperative residual block and associated adverse outcomes. We made our own study here within the last 5 years. This was conducted in 2 hospitals in the Philippines. We had 3 studies, and we found out that the incidence of residual paralysis in the PACU was between 30.2 to 38.8%, 38.2%. So what is residual paralysis? Residual paralysis or residual neuromuscular block is defined as a train of 4 ratio of 0.9. And this is associated with the presence of muscle weakness postoperatively after intraoperative use of neuromuscular blocking agents. So what is the importance of this? What is actually considered as a surrogate endpoint of adequate recovery of muscle function is a train of 4 ratio of 0.9 or greater, and it must be matched with ability to breathe normally, maintain a patent airway, preserve protective airway reflexes, swallow, cough, smile, and talk. General anesthesia is one of the techniques delivered for surgical and non-surgical procedures inside and outside the operating room. Neuromuscular blocking agents are usually administered during general anesthesia to facilitate endotracheal intubation, as well as to provide relaxation or immobility to optimize conditions for surgery, for example, for laparoscopic operations and craniotomies. So do we need neuromuscular blocking agents? As integral part of modern and balanced anesthetic regimen, neuromuscular blocking agents increase the probability of successful endotracheal intubation. Due to these improved intubating conditions, the incidence of laryngeal trauma and in conjunction the incidence of post-operative hoarseness and vocal cord injury is significantly reduced. In a randomized study by Menck, this was a prospective study, the numbers needed to harm for vocal cord lesions after intubation without muscle relaxant was 3.5, and the numbers needed to harm for postoperative hoarseness was 2.9. In other words, this study demonstrated that 1 out of 3 patients whose trachea was intubated without neuromuscular blocking agent had hoarseness afterwards, and 2 out of 7 patients had a vocal cord injury. Non-muscular blocking agent can also facilitate mechanical ventilation, so this is also an integral part of general anesthesia. If you will note at this slide, you will see vocal cord hematoma here, and here you have edema of the vocal cords. There are 2 types of, there are 2 mechanisms of actions for neuromuscular blocking agents. One is the depolarizing block, which acts in the same way as acetylcholine does. It binds the acetylcholine receptors and causes an initial depolarization of the muscle cell membrane. Hold on a second. Initial muscle cell membrane. The prolonged depolarization, actually this just shows you the succinylcholine or the depolarizing blocker. And once it occupies the alpha recognition site, the channel opens and sodium enters, and there's depolarization. On the other hand, if non-depolarizing block is used, what happens is that the non-depolarizing blocker will occupy one of the alpha recognition sites. And as you will note, it just needs to occupy one. It is actually in favor of the muscle relaxant, meaning that if you have less molecules, you can still achieve muscle relaxation. So once the molecule of the non-depolarizing blocker occupies one of the alpha recognition sites, the channel does not open and depolarization does not occur. And so there is no muscle contraction and there is muscle paralysis. There is great variability in reversal after a single intubating dose of neuromuscular blocking agents. Here, there are 3 neuromuscular blocking agents. They are intermediate acting, which were used by Devane in 2003. And what he did was he gave only one depolarizing dose of muscle relaxants and waited for spontaneous recovery. And you will note here on the right side that even as long as 120 minutes after the initial bolus dose of non-depolarizing muscle relaxant, there were still a lot of patients who had train of 4 ratio of less than 0.9, meaning that even with the use of intermediate muscle relaxant, whose duration of action is generally just 70 minutes, you still have patients who are paralyzed 120 minutes later, which is actually double the usual duration of action. So there is actually very great variability in the response to non-depolarizing, intermediate acting neuromuscular blocking agents. So what is the burden of residual paralysis? I think this is the more important thing that we have to learn as regards residual paralysis. This is a landmark study that was conducted by Beecher in 1954, and the study was conducted to find out the deaths associated with anesthesia and surgery based on almost 600,000 patients in 10 institutions. And what were found? Mortality rate when muscle relaxants were used was 6 times greater than the mortality rate when muscle relaxants or neuromuscular blocking agents were avoided. And the deaths with, they call this curare deaths, meaning associated with non-depolarizing muscle relaxants, were associated with respiratory failure. Then a little later, not a little later, but much later, in 1997, B.B. Mogensen and his colleagues, if you will remember, he was the author of the group that conducted the study that first noted residual neuromuscular block in the PACU in 1978. And he conducted this study to determine the incidence of post-operative curarization, meaning residual neuromuscular block, in 691 patients randomly assigned to different neuromuscular management, which was standardized at that time in the hospital in Copenhagen. All patients were reversed. The train of 4 was measured in the PACU by MMG, which is the gold standard in monitoring, and patients were examined on the post-operative day 1 to 6 for radiographic evidence of atelectasis and pulmonic infiltrates. What was found was 46 of the patients, or meaning 6.7%, displayed pneumonic infiltrations and or atelectasis following pancuronium, which is a long-acting non-depolarizing muscle relaxant, and vecuronium or atacurium, intermediate-acting neuromuscular muscle relaxant administration. And they found out that more post-operative paralysis was noted in the elderly as well as after abdominal surgery. This is also another interesting study which was conducted in about the same year. This was conducted by Eriksson, and this was in Sweden. And he noted that with residual block or residual paralysis, there is reduced hypoxic ventilatory response. If you will look here with pancuronium, with a train of 4 ratio of 0.7, there is reduced hypoxic ventilatory response compared to control. And this was also found with pancuronium, a long-acting, non-depolarizing muscle relaxant, as well as vecuronium, another intermediate-acting neuromuscular relaxant. This is another study, again by Erickson. He's a prolific author. And he noted that residual paralysis was associated with decreased upper esophageal sphincteric tone here, and with an increased pharyngoesophageal uncoordination. The end result of this is pharyngeal dysfunction, which actually increases the risk of aspiration in these patients. Murphy conducted a big cohort of 7,500 patients undergoing general anesthesia during a 1-year period. And he noted critical respiratory events and identified this in 61 of the patients. He took 42 of these patients and took another control of patients, another 42 patients in the same group who did not reveal or did not show critical respiratory events. And what he found out was, among the 7,500 patients, those who developed critical respiratory events had a train to 4 ratio in the PACU of 0.62 plus or minus 0.2, which is actually residual paralysis, if you will define it as a train to 4 ratio of less than 0.9. There are two processes which determine your muscular recovery from relaxants. One is spontaneous recovery from the neuromuscular blocker, meaning the process of elimination. And the other one is reversal through antagonism of the enzyme that breaks down acetylcholine or acetylcholinesterase, and or encapsulation of neuromuscular blocking agents by the new drug SUGAMMADEX. Neuromuscular blocking reversal follows this diagram. It can be antagonist of non-depolarizing neuromuscular blocker and antagonist of acetylcholinesterase, which is the enzyme that breaks down acetylcholine. So this actually has an indirect effect. What it does is, because of the antagonism of anticholinesterase, acetylcholine in the end plate increases, and there is actually more chances of depolarization. And the other one is encapsulation. These are encapsulation of steroidal muscle relaxants. And this is accomplished by the new drug SUGAMMADEX. So just a few salient points. Antagonism of neuromuscular block with anticholinesterase achieves maximum effect, meaning it has a ceiling within 7 to 11 minutes, after which reversal of paralysis becomes a function of spontaneous recovery. And because of the mechanism of action, there are associated muscarinic effects and from acetylcholine, and this require the use of anticholinergics. With SUGAMMADEX, there are less side effects because the mechanism is encapsulation and it does not have a ceiling at all. Complete reversal is achieved with optimal dose against the intensity of the block. So, this again was 35 years after the study of B.B. Mogensen in 1979. And this was the study of Brookman in 2015. And he noted that on 154 patients, the train of 4 ratio was measured in the PACU and at PACU entry. And all patients given SUGAMMADEX this time did not have any residual paralysis, while 33 of the usual care patients, meaning with or without reversal with neostigmine, had residual paralysis. Sasaki, in 2014, on 3,000 patients, noted that neostigmine reversal did not affect oxygenation, but was associated with increased atelectasis. And this is a frequent finding when neostigmine is used. And then high-dose neostigmine or unwarranted use of neostigmine may translate to increased postoperative respiratory morbidity because neostigmine on its own can produce muscular paralysis. This is just to show you the SUGAMMADEX dosing. For deep neuromuscular block, meaning post-tetanic count of 1 to 2, the dose is 4 milligrams per kilogram. If the block is down to a train of 4 count of 2, it's 2 milligrams per kilogram, and then so on. If the train of 4 count is 4, it's 1 milligram per kilogram, 0.5 milligrams per kilogram with a train of 4 ratio of 0.2. And if the train of 4 ratio is 0.5 or better, the dose is 0.25 milligrams per kilogram. This is supported by studies, but is still not in the packet, the pharma packet of the drug. So why do we reverse muscle relaxation? We reverse to prevent residual block or associated risk, meaning aspiration, impaired hypoxic ventilatory response, and associated lung complications postoperatively. And reversal of neuromuscular block is associated with decreased risk of postoperative death and coma, which was found by the study of Arbus in 2005. It also led to shorter stay in the operating room because the muscle relaxation is completely reversed in the OR itself, and then it decreases the patient's experiences, decreases the unpleasant experiences of patients associated with residual paralysis. Now, can clinical and qualitative monitoring of neuromuscular block predict adequate reversal of neuromuscular block? Just an introduction. We actually use quantitative, qualitative, and clinical parameters in monitoring adequate reversal of neuromuscular block. So if we are going to look at the study that was conducted in the Philippine General Hospital on 55 anesthesiologists, asking the question on how do you monitor intensity or depth of neuromuscular block, most of them answered visual observation of patient or diaphragmatic movement, meaning clinical parameters. Very few of them used quantitative monitoring, these two, as well as qualitative monitoring, which is the tactile observation of response of neuromuscular block monitor. So most of them, 34 of the 55, just looked and observed clinical parameters. And the same group was asked, how do you determine whether or not to antagonize residual neuromuscular block? And a lot of them, 24 of the 55, answered head lift, grasp, tongue depressor, etc., which are the clinical signs. So let's look at these clinical signs. How do they predict identifying the train of 4 of less than 0.9? So these clinical tests actually are the tongue depressor test, hand grip of 5 seconds, head lift of 5 seconds, general weakness, leg lift of 5 seconds, and smile, swallow, or speak. And if we look at the head lift of 5 seconds, it can only predict a train of 4 ratio of 0.5. So anything higher, which is in fact part of residual paralysis, the head lift cannot predict. So most of the clinical parameters that we use can only predict approximately 0.5 of the train of 4 ratio and cannot improve upon that. So these are the monitors that we use. On top is the Electromyography or AMG, which is a quantitative monitor. The kinemyography, which you find in the anesthesia machines of most hospitals now, is also another quantitative monitor. The peripheral nerve stimulator here is a qualitative monitor that, although it actually stimulates the ulnar nerve, what is observed is just the movement and the feel of the contraction of the thumb. So it is a qualitative monitor, it's not quantitative. So Murphy, in his study, looked at or compared the adequacy of monitoring that is achieved with the quantitative monitor or the qualitative monitor. Quantitative monitor, their endpoint was a train of 4 ratio greater than 0.8. And with the qualitative monitor, they just looked at the contraction of the thumb and observed the fade of the contraction as well as the clinical test, meaning head lift, tongue depressor test, leg lift, etc. And After this, in the PACU, they observed the train of 4 ratio. And in group 1, which is the quantitative group, there were only 4.5% of patients who had less than 0.9 train of 4 ratio against 30% of those using qualitative monitoring and clinical monitoring who had an endpoint of 30% of them had less than 0.9%. And among group 1, there were no signs of critical events, meaning a reduction in the oxygenation as well as obstruction and difficult airway. While in group 2, meaning those who had qualitative monitoring, there was a sizable number of patients who had a reduction in oxygen saturation, obstruction, as well as airway difficulties. These are the quantitative methods of monitoring that we have. You have the kinemaio, Oops. Yeah, okay. There is kinemyography, electromyography, and mechanomyography. And the patterns of stimulation that we use is single twitch, the train of 4, the post-tetanic count, and the double burst stimulation. You can maybe clinically in the operating room forget the single twitch and the double burst stimulation because the most useful among all of these patterns of stimulation in the operating room is the train of 4 and the post-tetanic count. Barack Obama said, the change will not come if we wait for some other person or some other time. We are the ones we've been waiting for. We are the change that we seek. So how do we now achieve the change that we have to do with preventing the occurrence of residual paralysis and preventing the associated pulmonary complications? This is the study of Baylard, which was in 2005. He's French, and they did this in 583 patients who were given vecuronium, an intermediate-acting neuromuscular blocking agents. There was no peripheral nerve stimulator that was used. Neostigmine was given only in 1 patient in the operating room, and the results were, in the PACU, 42% had a train of 4 ratio of less than 0.7. Well, what he did over the next 10 years was there was implementation of teaching programs on the use of neuromuscular monitoring and reversal of neuromuscular block, and they made available monitoring devices in all of the operating rooms in their hospital. And they actually made surveys, random surveys all throughout. The surveys were done first, the initial survey was in 1995, then it was followed 2000, and then 2002, and 2004, so that's over 10 years. And the results of on the last year, on 884 patients, was objective monitoring increased from 2 to 60% of patients. Reversal increased from 6 to 42% of patients. And in the PACU arrival, only 3% from 62% of patients had a train of 4 ratio of less than 0.9. What they did was they made monitoring equipments available, and then they encouraged the doctors to reverse the block whenever it was necessary. And this decreased the incidence of residual block in the PACU. Another study was conducted by Todd. You will remember that Todd was the one who observed the hidden universality of residual neuromuscular block. And he noted that in 2010, he noted that there were a lot of patients who had to undergo reintubation in the PACU, and this was associated with residual neuromuscular block. So they started putting electromyographic neuromuscular monitoring in all their operating rooms, meaning they made the electromyographic neuromuscular monitoring devices available in all their operating rooms. And the initial result, which was taken in August of 2011, was that the train of 4 ratio of patients in the PACU was rather high, at less than 3-to-4 ratio of 0.9 in the PACU, meaning patients who had residual paralysis was rather high at 31%. And those who were using quantitative monitoring was only 50%. Then in December of 2012, which is approximately 2 years later, by just making the equipment available in the operating room and conducting educational conducting lectures on the use of monitoring and the reversal of muscle relaxation, they were able to reduce the incidence of 3-to-4 ratio of less than 0.9 from 31% to 15% in 2 years. And they were able to increase the use of quantitative monitoring in the operating room to 83% from 50%. So it actually, these two last studies were actually similar. The one of the Bellard and the one of Todd. They only made the monitoring devices available in the operating room, in all operating rooms, and they conducted educational program on muscle relaxation, neuromuscular paralysis, reversal, and monitoring, and the results are similar. So what is the current status of neuromuscular monitoring and reversal? Postoperative residual neuromuscular block has been recognized as a potential problem for decades. Traditional antagonists are ineffective in reversing profound deep neuromuscular block, meaning the anticholinesterases or the antagonists. And anticholinesterases may induce paradoxical muscle weakness, as we have shown in one of the studies where neostigmine resulted in pulmonary complications because of muscle weakness. And SUGAMMADEX can reverse aminosteroidal neuromuscular block, but effect must be objectively monitored, meaning you must have an objective monitor at hand for you to be able to dose correctly with SUGAMMADEX, the muscle relaxation or the residual paralysis that you have. And objective monitoring, therefore, is mandatory, whether you are reversing or you are not reversing, you are just monitoring, you are spontaneously waiting for the patient to recover. As long as neuromuscular blocking agents are used, neuromuscular monitoring is mandatory. So we cannot solve our problems with the same thinking we used when we created them. This is Albert Einstein. So we have to do something about it. Thank you.
Thank you for that insightful lecture, Dr. Merle F. We now have 91 logged in through live streaming and 114 participants through Facebook Live. We would like to thank today's sponsor, Mark Sharp and Dome, MSD Philippines. We are now open for questions. For live stream viewers, please type your questions in the Q&A box. For Facebook Live viewers, please type your questions in the comments box. Our first question is, what is your say regarding the usage of exoskeleton? Is this feasible for Philippine use?
Exoskeleton?
I'm just reading the question. I don't know what exoskeleton is. Exoskeletons in insects.
I'm not sure I am capable of answering that question. If it can be clarified, maybe I can.
In the absence of neuromuscular stimulating devices, how long should we clinically observe for residual neuromuscular paralysis before we call for a neuroconsult?
As I said, if we can make neuromuscular monitoring universal, imperative for all patients, that actually is going to be best. If you don't have it, And you have all the parameters, the clinical parameters that was spelled out a while ago, meaning you have the patient is awake, you have tested him for head lift, leg lift, head lift. The most sensitive actually is the removal of a tongue depressor between clenched teeth, because the masseter is actually the most sensitive among all muscles to neuromuscular blocking agents. So if the patient can resist the removal of a tongue depressor or an airway between clenched teeth, then that actually is a pretty good indication that most of the muscles probably have recovered, but it does not indicate that all of the muscles are actually recovered, okay? What is important is for the patient to be able to protect himself against aspiration. So these are actually very sensitive muscles to muscle relaxant. I would suggest that if you have all of these parameters present and you do not have any muscle relaxants available, I will not suggest for you to use neostigmine, because that is not indicated for this patient now, okay? So what I would suggest is you either observe the patient and keep the patient in the PACU, not very far away from the nurses. And at the same time, if you have SUGAMMADEX, maybe you can give SUGAMMADEX at a dose of 1 milligram per kilogram. That is out of the prescribed dosing, but then there's a study that showed that it can be done. 1 milligram per kilogram of SUGAMMADEX, or observe the patient, put the patient in the PACU very close to the nurse's station. Wake the patient up, stimulate the patient up so that the patient is protecting himself.
It's my understanding that there's a worldwide move towards reversing all patients exposed to neuromuscular blockers against not reversing at all.
Yes.
What is your stand on this?
Well, I am an advocate of monitor all or reverse all. So if you haven't got
monitor all or reverse all, or monitor all and reverse all.
If the ideal situation is monitor all and reverse all, but if you have to choose, you monitor all or reverse all. If you do not have any monitor that tells you that you have adequate recovery from muscle relaxation, then you reverse. Just a word of caution though. Large doses of neostigmine, as well as doses of neostigmine that is no longer indicated, like a patient has practically completely recovered from non-depolarizing muscle relaxant. If you give neostigmine, you can get paralysis from it, because neostigmine can increase the acetylcholine so much, and acetylcholine itself can cause paralysis of the neuromuscular junction. So this is the reason why, if it is not, neostigmine is not indicated, or if you would like to use large doses of neostigmine, it is actually that is not recommended, because they have found out that if you do that, there are patients who develop pulmonary complications associated with muscular weakness.
So this is my understanding of that. If you were to use neostigmine as a muscle relaxant reverser for muscle relaxant reversal, then you must clearly identify its indication.
Yeah.
It should be indicated when it's used,
yes.
And it should be used with caution, because because it's what you intended initially for competitive antagonism can actually turn into acetylcholine activation of the junction and resultant paralysis.
Paralysis, yes, that's true.
Is neuromuscular monitoring widely available in the Philippines?
That's a sad thing, no? Many new anesthesia machines now have the neuromuscular kinesiomyography that is installed in the anesthesia machine. And in my experience in the many years of working in the department, I have come to the conclusion that I don't really know why, even if you have the monitors, there's actually a resistance of people to use the monitors. So I do not know. We have to conduct another study now and find out how many of our colleagues use the neuromuscular monitoring that are actually devices that are actually available in the anesthesia machines. But many years ago, when I was working in PGH, about 10 years ago, we had several stopwatches. And these stopwatches were all over the place. And they were only used in the cardiovascular room, in the neurosurgical room. The other services didn't use it at all. Even if you have the monitors, the people still are not very, very happy or very
receptive
with alacrity. No, there's no interest in using it.
There's it would seem that as far as the distribution of the use of neuromuscular monitoring all over the country, there is still little pockets of little groups that actually use it regularly, but this is more a rarity than a commonplace. As an anesthesiologist myself, I'd like to answer for everyone in saying that maybe the resistance is from the difficulty of the subject. It's neuromuscular monitoring is notoriously confusing. So maybe with your help, if we could have a roadshow on more neuromuscular monitoring and people learn how to use it more, then it would be more in use.
As a matter of fact, we conduct this. We actually appear, but we are a group, so we go to places and conduct what we call CAPE. The CAPE is actually continuous anesthesia programs in education or something like that on muscle relaxants. So we go to the place and then we conduct lectures and utilization of muscle relaxants and reversal in the operating room. Now, I think to make it easier, there's a program. I think these webinars are actually very good. And there are now programs which are webcasts. We call it webcasts. So we conduct the lectures and then interrupt the lectures and show demonstrations in the OR of how the muscle relaxants are monitored and reversed. I think that's very effective because then we do not have to go to the places. And then we conduct them, sit, and then conduct the program. So I think that is going to reach more people rather than for us to ride the plane and go there. That's what we've been doing. But we intend to change it so we can reach more people.
If neuromuscular monitors are not available, would you just then give SUGAMMADEX routinely for reversal? Would it be prudent to give SUGAMMADEX routinely?
Well, the dose of SUGAMMADEX is actually related to the intensity of the block. So if you do not have any monitoring device, it's a little bit difficult to objectively determine the intensity of the block. So I cannot give you offer and tell you now, okay, this patient is like this, and then you give 1 milligram per kilogram, that's okay. What I would say is, if you have all the clinical parameters satisfied, okay, meaning yung removal of the what do you call this? The tongue depressor between clenched teeth, and you have all that, you can maybe give 1 milligram per kilogram of SUGAMMADEX. But of course, that is not in their label. So that's off-label, okay? Off-label.
So what we're talking about is empiric use of the option of using SUGAMMADEX empirically for unmonitored delivery of neuromuscular blockade. What about empiric usage of neostigmine?
I'm not quite happy over that because, as I said, if you are actually reversed already, you do not know the degree of reversal that you have. All right? You are reversed, you don't know the degree of reversal because you don't have any monitor. You have all the clinical parameters satisfied. You know exactly where you are. So you have actually a maybe adequately reversed patient or not, spontaneously reversed or not. So if you give SUGAMMADEX, if you give neostigmine, you might be using a high dose and maybe courting some trouble in terms of increasing the acetylcholine in the neuromuscular junction.
What you're saying is, if you already fulfill the clinical parameters for neuromuscular reversal, then giving neostigmine empirically
will probably be
more detrimental.
Harmful, very detrimental than that. What I would suggest, if you do not like to reverse and you do not have SUGAMMADEX, you just wait. Bantay your patient.
That's right. Leb Nonog, are you listening? That's what I told you earlier today. Okay.
Okay.
Do you have any more questions? If you could give us sorry, there's one more last question. Is SUGAMMADEX available in the formulary, in the Philippine National Formulary?
I do not know. I do not know. I haven't looked.
National Formulary, SUGAMMADEX?
PNF.
Remember, what we're talking about here is are the two main neuromuscular, the muscle relaxant reversal agents, which are neostigmine and SUGAMMADEX. Neostigmine acts by competitive inhibition, whereas SUGAMMADEX encapsulates the relaxant.
Yes.
So these are the two main things we're talking about. I'm sure many of you are confused because even anesthesiologists get confused with this subject. So I'm just clarifying that because we've been talking about this for a while. The formulary available in the Philippines.
Is it? Yeah.
I'm supposed to spiel a little bit more while we're checking the formulary question.
Okay.
It is available in the Philippine National Formulary.
Yes.
So as Dr. Odi mentioned earlier, there may be a little bit more room for empiric management of SUGAMMADEX than neostigmine, because would it be safe to say that you will be more prone to committing a sin of commission if you give neostigmine empirically as opposed to giving SUGAMMADEX empirically?
Yes, I think so.
You think so?
I think so.
So it's a little bit safer to give SUGAMMADEX if you were to give it empirically.
Yeah, and actually studies are now being conducted to relate the dose of SUGAMMADEX to the reversal, the intensity of the block or the intensity of the residual block of patients. So meaning if you have a train-off ratio of this, then you give this much. Let's say, let me make an example. If you have a train-off ratio of 0.5, then you can just give 0.25 milligrams per kilogram of SUGAMMADEX. And then you increase according to the intensity of block. But then again, it will require monitoring.
Yeah. That's what it all boils down to that, kids. So
monitoring
the people
and
who think,
reversal.
anesthesiologists who think that you can get away without knowing how to use neuromuscular monitoring, well, with the advent of reversal, there's just no option except to know how to do this. Which brings us to another question: is neuromuscular monitoring widely available in most hospitals?
In tertiary hospitals, I think the new machines, there's actually an increase in new machines even in DOH hospitals. And the new machines have actually, in the machine itself, is a neuromuscular monitoring device, usually a kinesiomyography. So it can be used. You just routinely use it. It just touch it and see what happens. What I would suggest is just play around with it. The familiarization.
That you don't understand.
Never mind. Things will come into place once you look at it, diba? You just attach it. Familiarity.
Actually, there's I've seen that monitor with which can read TOF ratios for you. When you get TOF ratios, then paralysis can be controlled very tightly, very concisely. Finally, it's been. I've seen these monitors in several hospitals, several tertiary hospitals. but there is a resistance to its use now.
Yeah.
Most people do not want to use it because they're afraid to interpret, they're afraid to
be thought stupid.
Yeah. Actually, basically that's it. Nobody likes using it because, long and short of it is, what's the point in having it if you don't know how to use it? And many people just don't know how to use the monitors. But many machines now have incorporated UF ratios. I've even seen them in the provinces.
Yeah, and in the accreditation hospitals.
Yes.
But remember that the people, that the hospitals that you are accrediting are actually tertiary hospitals who are actually training. So these are training programs, so they will be having all the monitors required.
Yes,
I do not know
having
about
the monitors is very different from interpreting. Despite the fact that we consider neuromuscular monitoring as part of the armamentarium, the regular armamentarium of the anesthesiology of the millennium, sadly, I would say that maybe 30% of practitioners are actually adept in the use of monitoring. Only 30%. It's a very weird topic, so I'm not really exactly sure how if we were able to get through to the audience.
No, but what I'm going to say is this. Alam mo yung sasabihin ko, I forgot na nga.
Sorry.
Anyway, following the studies, the last two studies that I showed, this is the study of Baylard, which was written in 2005, and the last study was written, I think, in 2015 by Todd. And they did exactly the same thing, except that they did it in one hospital lamang. So this study was conducted by Todd in his hospital in 2015. And all he did was made the monitor available and educate. So if we can do that in each of the hospitals which have the monitors, we are going to have an increase in the number of people who are monitoring and who are reversing. Just that. Make the monitor available and train. And survey. Para merong periodic survey on whether it is improving or not.
Actually, if you think about it, maybe that would apply for majority of the forms of technology, because like the point of care testing, yung mga instant ABGs, nung time namin yung necessity, tinatakbo pa namin yan sa lab.
Oo, alam ko yun. Maski kami.
Di ba ABG, tinatakbo pa kami sa lab, dala namin. Ngayon, point of care na lang sila right there and then. And surprisingly, yung kids namin ngayon, mga first years, actually know how to use the point of care testing because it's available to them.
And then they have to understand now how to interpret the results that they get from the point of care.
Yeah.
They have to, because it's there, di ba? Yes.
Okay, so that's an interesting discussion. Thank you, Dr. Merle Odi. After this session, the link to the evaluation form will be emailed to the email address you entered in the attendance form. Please answer it immediately to get a copy of your certificates a week after the webinar. Webinar recordings of our previous webinars are now available at the UP Manila official YouTube page. You may access the following webinars through the link flashed on your screen. Thank you for joining us. We would also like to thank our sponsor, MSD Philippines, for their support to this webinar. We hope to see you again in our upcoming webinar on March 20, Wednesday, 12 to 1 p.m. Manila time with our speaker, Dr. Cecilia Jimeno, who's here today, incidentally, including last year's speaker, Dr. Jean Torad.
Last week.
Next week's webinar is entitled Tuberculosis and Diabetes, sponsored also by MSD Philippines. Please invite your colleagues to join this continuing weekly CME webinar series. All webinar schedules and resources will be posted at http://facebook.com UPMedWebinars. You may also email us at upmedwebinars2019@gmail.com for any inquiries. On behalf of UPCM Class 1994 and the UP Medical Alumni Society, we also thank our collaborator units, UP College of Medicine, Postgraduate Institute of Medicine, the UP Manila Information Management Systems, IMS, and AHIN. This is Dr. Tigran Odi with Dr. Merle Odi and the UP Medicine webinar team closing this session. We hope you've learned a lot from today's webinar. Join us again on March 20. Please also join the 2019 Aging and Longevity webinars every second and last Friday of the month, as well as the upcoming Lenten webinars by UPCM Class 1990. Thank you.